Good afternoon to everyone present here. So this IC is mainly related to intraocular tumors, and we have a good group of presenters who will be taking us to different aspects of intraocular tumors. I will be kickstarting this session with my presentation on intraocular vascular lesions. So I will be going through certain differential diagnosis of these vascular lesions, their diagnostic characteristics, and their systemic significance. We'll start off with choroidal hemangioma. It is one of the most common vascular lesions that are seen in the fundus. It's basically a vascular hematoma which presents with metamorphopsia, blurred vision, induced hypermetropia, increased intraocular pressure, among other symptoms. It can be either circumscribed or it can be in the diffuse form with a nodular component. So clinically, it has this reddish orange to yellow hue, and it is most likely will be found closer to the posterior pole. Thickness varies from about 1 to 3 millimeters, and it usually has some amount of RP degeneration because these are long-standing lesions, and active lesions do have subretinal fluid that can be seen around the lesions as serous retinal detachment. Diffuse choroidal hemangiomas have a more saturated red appearance to the fundus, and the choroid is thickened diffusely as it can be seen on ultrasonography. If this thickening is more prominent around the disc, it may make it look like there is prominent optic disc cupping. These patients usually have Sturge-Weber syndrome, and that's why they might have elevated intraocular pressures associated. Again, RPE changes and serous retinal detachment are commonly found in these patients. This is the autofluorescence, which shows hypoautofluorescent patches in the region of the actual lesion. And wherever there is subretinal fluid, you do see this RPE hyperactivity as this hyperautofluorescent lesions. OCT is good to demonstrate this dome-shaped lesion, which is basically occupying the middle and the outer layers of the choroid with no choriocapillaris compression. Subretinal fluid and intraretinal fluid is easily seen on OCT, and OCT is a good tool for monitoring the activity of this lesion. The ultrasound is the one that really gives away the diagnosis. Basically, there's this acoustically solid dome-shaped mass with high internal reflectivity seen on A scan, which is basically due to the multiple vascular channels within the lesion. The fundus fluorescein angiography shows this early, very early hyperfluorescent lesion or filling up of the vascular channels within the mass itself. And towards the late frames, it undergoes staining and some amount of leakage where there is subretinal fluid. The ICG is another modality which is actually better to delineate these lesions. And it also shows within 30 seconds, the lesion kind of fills up and there's progressive hypercyanescence, which is seen after 3 to 4 minutes into this investigative modality. Diffuse choroidal hemangiomas, as I previously mentioned, is associated with Sturge-Weber syndrome, which can be easily seen in this boy as this porcine stain. They're more commonly associated with glaucoma, but we should be careful looking out for this diffuse choroidal hemangioma, as it may be associated with a lot of subretinal fluid and secondary retinal detachment. Treatment is if it's a small lesion, it can be amenable to local treatments like photodynamic therapy, TTT, laser. If there are larger lesions, they might require EBRT or plaque radiotherapy, or even gamma knife radiosurgery has been tried. Anti-VEGF agents and oral propranolol have been used to a certain degree with moderate success. This is a patient who has undergone of diffuse choroidal hemangioma, who has undergone plaque brachytherapy with good resolution and stable follow-up 1 year post-treatment. The next lesion we'll be talking about is retinal capillary hemangioma. It's basically a benign vascular lesion, which is a red-yellow lesion with this dilated feeder artery and feeder draining vein. Average age of presentation is about 15 to 35 years. The lesion is most often, like 84% of them are associated with von Hippel-Lindau syndrome. And in this case, they tend to be multiple and bilateral. These are some of photographs showing these fat dilated feeder vessels which lead up to this large lesion. Optos fundus photography really helps because you can see these peripheral lesions along with the associated retinal detachment, and some very subtle lesions may be seen more easily. Fluorescein angiography is really important because some of these lesions are so small you might miss it on fundus examination. They fill up rapidly, the feeding artery, the lesion itself, and the draining vein, they fill up very rapidly with fluorescein leakage. As you can see in this photograph, it is very good for diagnosing occult lesions. Small lesions may be observed or may be amenable to local therapy. Larger lesions might require vitreoretinal surgery. Oropropranolol and anti-VEGF agents have had equivocal results. The most important thing is the systemic screening, because these, as part of a VHL syndrome, CNS hemangioblastomas, RCCs, pheochromocytomas may be seen. So it is recommended that patients undergo physical examination, dilated fundus examination, urinary metanephrines, and abdominal ultrasound yearly, along with supplemental abdominal and brain MRI. The next lesion is retinal cavernous hemangioma. It's very classic. It looks like this bunch of grapes appearance. It's mainly centered around the optic disc and in the macular area. They are basically comprised of thin-walled channels with surface vascular channels with surface gliosis and non-penetrated endothelium. They're usually sporadic and asymptomatic unless they involve the macula or have some bleeding associated. What is characteristic is this, it's for fluorescein angiography, where you see this layered appearance. Due to the slow flow of blood through these lesions, the plasma is separated in the upper section and the erythrocytes settled at the bottom. So the upper part is more hyperfluorescent and the lower part is hypofluorescent, giving this layered appearance. There is no leakage of these lesions. These lesions may be easily observed and only be treated if they are symptomatic. This is one of our departmental publications where an infant presenting with APROP also had a retinal cavernous hemangioma, but since it was asymptomatic, it was left alone and it has been stable. The next lesion is racemose angioma of the retina. It's basically associated with Wyburn-Mason syndrome, in which there are arteriovenous malformations of the brain, orbit, retina, and skin. More often than not, there is focal involvement that is seen. These are the fat dilated vessels that you can see arising from the disc. Whenever you see this, it almost clinches the diagnosis. These AVMs were classified according to their severity, with a group 3 having complex and extensive AVMs, which tend to have more complications and are more symptomatic. These retinal AVMs can lead to retinal detachment, macular edema, vitreous hemorrhage, retinal vascular occlusions, and at later stages, neovascular glaucoma, optic atrophy, and visual field defects. FA demonstrates rapid filling of these lesions, and it helps in categorizing into the groups of AVMs that we previously saw. But there is no leakage from these vessels that is seen. It is very important for all these patients to undergo an MRI or MRA to rule out any cerebral AVMs. Treatment is only done in case of complications. Otherwise, the retinal lesions are regularly monitored. The next lesion is vasoproliferative retinal tumor. They're basically a red, irregular nodules that are seen in the periphery of the retina between the equator and the ora. They are yellow-red and ill-defined, more commonly found inferiorly or inferotemporally. They're basically comprised of glial cells and a network of capillaries with some larger dilated blood vessels. They may be either primary in most cases or secondary to retinitis pigmentosa, pars planitis, Coats disease, amongst other conditions. So the problem with these lesions is that even though they're actually small, they tend to have an exuberant exudation, which often reaches the macula, causing decreased vision. Epiretinal membranes are also found very often with these lesions. So the treatment is local therapy, mainly in the form of cryotherapy, laser, PDT, or plaque radiotherapy. This leads to a resolution of subretinal fluid and eventually the MASTO. Just to kind of put everything else together, there are a few iris vascular lesions which are usually benign. Iris capillary hemangiomas may be associated with eyelid and orbital capillary hemangiomas. Iris cavernous hemangiomas are known, and racemose hemangiomas are also known. They're basically benign conditions that can be watched. So to summarize, we've gone through a lot of intraocular vascular lesions, their classic clinical appearance, and ancillary testing, especially FFA, is very useful in diagnosing these conditions. We've seen the systemic implications, especially in case of retinal capillary hemangioma, cavernous hemangioma, and racemose angioma. These patients should undergo, at least on the first visit and follow-up visits, a good brain and brain MRI and MRA. I would like to acknowledge Dr. Santosh Nawar for the photographs and for giving me all this knowledge, and also the Retina Department at Advanced Eye Center to help me, for helping me with all the photographs. Thank you so much.